one on their phone, that would be very helpful. Oh, good. That sounds much better already. Thanks, everyone. So we're going to go ahead and get started with this Research into Action webinar. My name is Carolina Deuce, and I'm an Evaluation and Research Senior Associate here at CADCA. One of the goals of our team is to gather data just to evaluate our trainings and our conferences, to see what our members need from our trainings and our other services that we offer. But another thing the Evaluation and Research team does is works to connect coalition members with current academic research that's out there that affects us in the substance abuse prevention field. With that in mind, this webinar features an article called Developing a Productive Workgroup Within a Community Coalition, Transtheoretical Model Processes, Stages of Change and Lessons Learned. And Dr. Jennifer Langhinrichsen-Rohling and Emily Blejwas and Sherry Archer will be discussing their article for us this afternoon. One more plea to push *1 on your phone to mute things. If your name is not Dr. Langhinrichsen-Rohling, Ms. Blejwas, or Ms. Archer.
Okay, can everyone hear me? Let's get started. Hi, I'm Jenny Langhinrichsen-Rohling, and I'm a professor of psychology at a clinical psychologist at the University of South Alabama. And my passion is around integrated care and particularly providing the best level of care we can to patient populations that are traditionally under-resourced and underserved. Mrs.
Good afternoon. I'm Sherry Archer with Ozanam Charitable Pharmacy. Ozanam is a free pharmacy that has existed for 20 years in Mobile, Baldwin, and Escambia counties in Lower Alabama. And our primary focus is to provide no-cost medication to individuals who lack health insurance and who lack the ability to pay.
I'm sorry to jump in here, but we're having trouble hearing. Could you speak up a little bit?
Center, which is an NIH-funded health policy research center. We're located in Biola Battery, Alabama, right on the Gulf of Mexico, and we serve the 5 states that touch the Gulf of Mexico, so Florida, Alabama, Mississippi, Texas, and Louisiana.
So this is Dr. Alar again, and I'm going to talk to you a little bit about the structure of today's webinar. First, we're going to do a very brief orientation to our work group, which we like to think of as sort of a coalition nested within a coalition. Then Emily's going to talk to you a little bit about the structure of the Gulf States Health Policy Coalition, the assets and constraints, and also how we documented the processes and the products that have created, because part of the way that our coalition sustains itself is by being nested into this other superordinate kind of structure. And then we're going to talk specifically about the paper, why we use the Transtheoretical Model to frame our efforts, what is this, and how did this help us. And then Shree's going to talk about some of the results that were specific to the nonprofit, to the charitable pharmacy. And I'm going to talk a little bit about some of the things that we have as outcomes and how we looked at outcomes for our work group as a whole. And then we're going to end with some conclusions, lessons learned, generalizations that we hope will provoke questions from you that we would love to discuss. And to let you know, we actually are all sitting together in an office so that we're happy to pass the phone around and to share insights and also some of the difficulties that we've experienced.
Okay, this is Emily. So I'm going to talk a little bit about the Gulf States Health Policy Center and the structure. So the Gulf States Health Policy Center Our mission is to conduct health policy research and foster collaborations and partnerships in order to improve health equity and health outcomes in the Gulf states. So we were founded by Dr. Regina Benjamin, who served as the 18th U.S. Surgeon General under President Obama. Prior to that, she was a family physician in Bayou La Battery, Alabama, which is a rural area right on the Gulf of Mexico. And so when she left Washington, she founded the Policy Center as sort of a marriage between her experience as a family physician in a rural setting and also her top-down sort of policy knowledge. But at the center, we take a really grassroots inclusive approach to policy. So we look at local policy, we look at state policy, but we also look at policies of organizations and schools and cities. So I'm going to tell you a little bit about, so the coalition, which is where this research project came out of, really looks at bringing together people from all different organizations to work together on health issues. And we take a really broad approach. That's why I included the National Prevention Strategy. So we look at kind of a health in all policies approach, and we particularly are interested in social determinants of health. So on our coalition, we bring in people who work on fair housing, people who work like Cherie does on pharmacy. We bring in especially look to connect university and community. So for instance, on our research project, all of our research projects are led by co-PIs, one from a community organization and one from an academic institution. And we also have a fellows program where we train community members and people who work at nonprofits in research so they can better understand research and use it in their own work. So that's really at the center of everything that we do, bringing people together, especially bringing the community and academic perspectives together. So we have a coalition that meets monthly in 4 different areas. They meet in Bayou La Battery.
I'm sorry to interrupt, but can you get rid of some of the background noise, which is now louder than the presenter?
I'm sorry, I have to leave that up to everyone else on the phone, so I will reiterate, if everyone on the phone can mute themselves using *1 and also mute their computer, that would be very helpful for everyone else to hear. Thank you. Go ahead again, Emily.
Okay, I'll try to talk louder too. I'm sorry about that. I know that's hard on these calls with so many people especially. So our coalition meets in 4 locations. We meet on a monthly basis. We meet in Bayou La Battery, Alabama, which is where the work that we're going to talk about came out of today. We also meet in Birmingham, Alabama, in Hattiesburg, Mississippi, and in Biloxi, Mississippi. And we're always focused on research and policy. So the purpose of that coalition, while we build relationships and networks, really what we're charging our members to do is to conduct health policy research. And so we let each coalition branch come up with its own policy focus areas based on their interests and based on the needs and opportunities of that particular region. And so in Bayou La Battery, the coalition is focused on health literacy, financial literacy, and education. And so those 3 policy focus areas kind of came up from the coalition members. And this project that we're talking about today came out of the health literacy focus area. So I'm going to pass the phone to Dr. LR so she can tell you a little bit about how that work came to be.
So in our case, we self-selected into our work group. So we self-selected into our coalition that was nested into the larger coalition. And within our work group, we had time to get to know each other in these larger coalition meetings. We had breakout sessions. And in our breakout session, people shared, like, what is your interest in health literacy? What policies do you know about? What things are you concerned about? And one of the things that was shared by a pharmacist who's worked for a very long time in a low-income, under-resourced part of our community, he told the group about medication therapy management, which we have on the slide as MTM, which is basically allowing pharmacists to practice at the top of their license. So when you go to the pharmacist, they can talk to you about if you're on multiple medications for the same thing, or if your dosage doesn't seem to be right, or if you're having side effects. And because he worked in a sort of a one-stop pharmacy, he had done a lot of and seen a lot of cases where people in the neighborhood were on 3 or 4 different medications for their diabetes. And so he was very worried about patients with low literacy about diabetes and medicine. And this was the galvanizing force for the rest of us who had interests that were related. For example, my interest was really in integrated health and how having an integrated healthcare team that could include a psychologist, it could include a pharmacist, it could include other members of your healthcare team. If they're all on the same page, then you're much less likely to get into a situation where you're prescribed multiple medications by different providers for the same condition. So in our particular health literacy group, we had a number of organizations already represented. So Auburn University, the School of Pharmacy, Me and My Health, the Osnom Charitable Pharmacy, and you're going to hear more about that because that's where our study is actually taking place, the Mobile Public Health Department, Publix Pharmacy, and then where I'm from, which is the University of South Alabama. But I am a psychologist, and I was leading the Gulf Coast Behavioral Health and Resiliency Center. But we also had people who were from the School of Nursing and the Mitchell Cancer Institute, some of whom were practitioners and some of whom were policymakers. So the research question that we came up with, it's important to note that this wasn't like day one in our first breakout group. This was sort of like 6 months in, and we had a lot of education around what this policy was. We had education around how do you do policy level research? What does that look like? What does that mean? And that was all part of being in this larger coalition. But the research question we came up with was, does including a pharmacist in the integrated health team, one who's trained to provide medication therapy management, improve the care of under-resourced patients who are struggling with diabetes? Okay, so that was our research question. And we began to design a study that could give us data that would address that research question. But as we were doing that, we quickly realized that we didn't have enough time to actually really figure out the nuts and bolts of a rather complex research project with little to no resources, that was being put together by volunteers just in this one large sort of monthly coalition meeting. So we chose to meet outside the group. And we chose actually to have several occasions that were 2 or 3 hours in length where we brought food together. And it was in those sort of voluntary breakout sessions that we arranged that we both, made stronger connections with the coalition and with each other. And we also really put the finishing touches on the project that we wanted to do. So as our work group kind of continued on our path, and that remember there were 2 other work groups that were also in the Bayou Battery Coalition, we noticed that we seemed to be particularly successful in terms of we were getting things done, and we also were having a lot of fun with each other too, and really had developed some really nice relationships that were very supportive and successful. And because of that, we were pushed a little by the larger coalition to start trying to figure out what is it that made our coalition more successful. And that's really what led to the paper that you all have access to and have read for today's webinar, which is like, what are the nuts and bolts of developing a successful coalition or work group, and what did we notice? And we figured out what we did in a number of ways. We had written questions that we all reflected on. We had multiple sort of large conversations. We coded our data. But some of this, of course, is our own idiographic experience of being in the coalition, which we're happy to share with you. But we figured out that one of the things that happened very early on was that this leading community pharmacist and I published a paper. and we published a paper in this in a pharmacy journal, and I'm a psychologist. As an academic, I've never published in a pharmacy journal. Now, so that was out of my comfort zone. But really what we did was we found a place to give voice to our community pharmacists about why we needed this policy in Alabama. And so he made that case. We got it published, and that sort of galvanized the group that we actually can accomplish things, we can finish things. So we recommend an early win if you can for your group. We also set a lot of parameters to help our research project move along as effectively as possible. There's a lot to research project. When you work with academic partners, they tend to be not on the same timeline as your program partners. And so, for example, before we do any sort of research project, we have to have what we call IRB approval. So it's an institutional review board that looks at the ethics of what we're doing. And that process can take up to, 3 to 6 months for the project. We wanted our project to be scientifically rigorous, so we actually wanted to randomly assign our patients to different conditions, which meant that we had to really think carefully about, like, what were our patients getting? Could we do this in a very small pharmacy? And do we pose danger of hurting anyone? We also mostly are running our study with graduate student pharmacists. In fact, the newest one is in our room today with us. We ended up seeing that one of our outcomes was really helping these graduate student pharmacists get on-the-job research skills and showing them the benefits of, while they're practicing in a CVS or a Publix, that they can still do academic work and partner with academic institutions to make their practices more effective. We also really were noting patient involvement in the project and success. And one of the things that was really, just dramatic for us very early was that as part of our project, we decided when they came to the pharmacy to pick up their medication, we wanted to see what their blood sugar levels were. And so we instituted a protocol that we would check their blood sugar as they were getting their medication. And very early on, we had 2 or 3 patients whose blood sugar levels were like in the 500 level, which basically is a coma. It really is. And so as they were picking up their medication, we saw that having some way to detect what was going on for these patients, and in one case, we feel like essentially lives were saved in this. So that was all very energizing for our group. Okay. So I don't know the extent to which I think most of you do work in substance abuse, and if you do work in substance abuse, you're likely to be familiar with the Transtheoretical Model. It's usually applied to how you help individuals change as opposed to how you help a group change. So the idea of the model is that there are multiple stages to change. And it used to be, as a therapist, when people came into session, we would think that they're already in the action stage. Basically, they're coming in, they're ready to change. We just have to talk with them a little bit, and they're going to change. What we learned is that actually people cycle through this stage of change model where some people are actually in what we call pre-contemplation. They haven't even realized that their diabetes is a problem, or their diet's a problem, or their exercise is a problem. Some people are in contemplation, they're thinking about it, but they haven't done anything. Then there's sort of a preparation stage before you actually initiate any change. Then there's the change stage. And even more importantly, after you've made the change, there's also a maintenance stage. Like, how do you keep this change going? And for many people making a significant change, there also is a relapse period. And we know, for example, quitting smoking, any sort of addictive process, multiple relapses are more the norm than not. So what we did was we said, hey, can we apply this model to our group? And can we see where we as a group are? How did our group go from pre-contemplation, really where most people in our work group did not know what MTM even was, did not know it was a problem, did not know that we are Alabama is the only state in the United States not to recognize pharmacists to their highest degree. So we didn't have any awareness. Then we kind of contemplated that this was a policy issue. Then we tried to figure out, well, what kind of data would we need to show our lawmakers or legislators that this is actually something that needs to be done. So our group itself went through this process. Okay. This also is really helpful because underneath the TTM model, Prochaska and DiClemente talked about, like, what are the things you need to do to help people, like, change? And so I've just highlighted a few things here, but one of the things that keeps people changing or helps move people through the change process is if they have social support. And so that's also true for a work group. Like, the degree to which the work group is supportive and connected actually makes it easier to feel that you're part of that group, to trust the process, and to be part of that. So we paid attention to how we were supporting each other. Obviously, raising the awareness of the problem, and then getting passionate about it. If you want people to stay involved to a coalition, they have to recognize, what part of this problem do I actually really care about? Because I'm giving up my time, I'm giving my energy. And that's where, when we had some people whose sugar levels were over 500, we really had a lot of passion generated for our work group, and that created basically a deeper commitment and a deeper investment in the process. I think it's also really worth noting that the work was personally relevant for people in our coalition in really different ways. And yet, if you want people to keep coming back, they actually have to come back because the work is relevant for them. So you have to figure out, like, why is this person from the cancer center, who's kind of a policy person, coming to a group about MTM for pharmacy and a free pharmacist? Like, what is his link? How is this relevant to him? And how do we make it more relevant? And then we've talked a lot about reinforcement management. This is also really important when people are changing. And when groups are changing, you want multiple wins across the life of the project. We also noted that, and this we learned, I think, in contrast to some of the experiences we had post-Katrina and post some of the disasters we've experienced here in the Gulf Coast, that because we were focusing on policy instead of on the level of program, and our policy was about patient care, which we were all connected to, there was really a lack of competition. Like, we weren't fighting to get a grant or get resources or, so we weren't playing against each other. We were actually on the same team. And the more that we highlighted that, the better our group worked. Okay, so this is just to show, this is an academic slide, which is essentially one of the ways that the larger coalition was looking at how our group worked, is that they did some what they call social network analyses, and you can see that there's a lot of people. If you look at the left side, pre-coalition, there's a lot of people who sort of know one or two people, but they're out there. There's a whole bunch of people on the outskirts of this group that are really independent from one another. They don't know many people. And as you see in the on the right side of your slide, by a couple years into the coalition, there's a really dense connecting pathway of exchanges. So the people who are in the coalition now, who are deeply in the coalition, have lots of connections with one another, not just coming to the once-a-month meeting. And that's really an essential part of creating and establishing a good coalition. So I think maybe I've spoken mostly about the results for the whole coalition, but just to highlight a few additional things, like we did have, and there is, some models that show that if you have this overall structure that's supporting the work financially, to some degree, or at least, with emotional support, that's important. And our overall structure, the Gulf States Health Policy Center, did provide us monthly meetings. They inspired us. They brought people in we could learn from. We sat in a U shape, which really meant we were all looking at each other. We were close to each other. And that group provided a platform for building trust and relationships. So to some extent, having somebody who's really working for your group that is paid or has dedicated time to really making that overall coalition work, I think is essential. Or we're all nodding. We all think it's somewhat essential. We also had an action plan structure, and we did action planning activities like every 3 months. I mean, we just came back to it over and over. So we really kept moving from vision to action. We also really learned a lot about what policy is. So when we first started, the policy we were looking at is the state level policy, and there was some discouragement among our members because we know what our state legislature kind of looks like. Are we really going to be able to pass this policy? Are we going to be blocked, blah, 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 in these various ways? And one of the things that happened was that we realized that there's also policy at the level of the pharmacy. There's policy at the level of the healthcare provider who's providing, who's making these prescriptions, who's providing these medication. And I think Ms. Archer-Cherie is going to tell you a little bit more about that. Let's see. And I think really, that shift. So thinking about policy, and including policy members. So here's a coalition that moved beyond just program meeting people reporting about their activities and their programs, to including academics and researchers, to including community members, and to including people at the policy level was really essential, because at the policy level, they're saying you embed these policies in an agency, that's going to make this change sustainable. And for a coalition member, it feels really gratifying to know that the work you're doing is going to outlast your commitment in that particular group. Okay, next is Shri.
One of the greatest things that I've gotten.
I'm sorry to interrupt, but we can hear whoever is typing on their computer.
Can you hear me? Okay. It's being a part of this work group that actually started from the whole coalition. The relationship started to build from there, and from there we developed a work group with diverse group of people with different engagement styles, different age, different levels of career, from organizational directors to coordinators. And I believe that's what made the work group interesting, and it kept us together. And also, people joined the work group for different reasons. They joined for different reasons, but yet we had a common goal. We had a common goal with working with low-income patients and providing them with improved health outcomes. And that, I believe I saw that in every work group member. Our patients actually came first. Being in the work group helped us to establish new connections, and we worked strategically in brainstorming and developing ideas. And I believe that in this particular work group, egos were left at the door. Everybody was humbled and wanted to know more about the organization that the project was going to be held in, and also more about the patients. What was unique about this particular work group is that we actually met in the setting where the project was going to take place. So the members of the work group was able to see the operations in real time, even some of our struggles, by having so many patients come in through the door and so few volunteers to assist the patients. We were able to, with the work group, level existing relationships outside the coalition to contribute to the project's success. Working collaboratively allowed the work group to level resources in various other areas. And from time to time, we had members in key leadership roles. Either there was an illness or the person had to step out to help somebody else. But we had other members because we always had a task rolling forward. We always had a mission. And so there was always someone to step up and to fill in for that person until they could return. And we also published a paper that that gave the group early success. You know, it was pretty cool for a community-based nonprofit to be published in the Johns Hopkins Journal of Medicine, and I have to say that from time to time, some of my IQ points will rise. And so, but what I believe, as for the community-based organization, which is Asanam, I believe that having this work group as a part of the family, because I really believe over a course of time we built strong relationships, and so having the work group as a part of the Asanam family helped our organization as a nonprofit to be a stronger organization, not just on the local level, but also on the state level and the national level. Having the diverse group of stakeholders help us to connect with the university, to build that partnership, really helped our organization in many good ways. So basically, it helped us to see some of our broken parts because we were able to brainstorm, and during the brainstorming, we came to some epiphanies like, wow, we haven't connected with the hospital systems in the area, so maybe we need to join the transitional care team, work with the hospital systems so that we can teach the transitional care teams how to teach patients who lack health insurance how to access medication quickly so that they won't return in 30 days, causing issues with the hospital system. So now we're a part of a transitional care team. It also helped our nonprofit to connect with the provider which we're working with the study. Ironically, we've been partners with the provider, with the health department for 20 years. But up until years ago, we had never met during a provider's meeting. So now we have a relationship with the health department, and we try to meet quarterly with the providers to help them to understand what we're doing as an organization to help their patients. We have, with our FQIC, which is the health department, 250 mutual patients. And so we're able to talk directly with the physicians there. And that's something that really came out of being a part of this work group. And being a part of the work group also gave us real-time, real feedback, so that we can troubleshoot some of the issues in the community. And before we could get anything done, we actually had, because I have 22 bosses, I have 22 board members, we had to meet with our board to get them to buy into having a study at our organization. So we had to get both board buy-in, staff buy-in, and volunteers, because many of the good folks who work for the free pharmacy are volunteers. And so all of that came together and helped us to establish a stronger connection with the community and with the work group. Okay, so now I turn it back over to Dr. Law.
So, given the little glitch with our phone call-in, I see that we're a little over time, so I'm going to be very quick here in terms of our lessons learned. But we definitely think that successful partnerships do need time and energy to develop, and they also really need to have a collective mission. And kind of reinforcing that mission, getting people to feel passionate about that mission is really important. We're big believers in getting diverse people in your group. For us, not only do we have policy, program, practice, and patient perspectives, but we had visionaries, we had leaders, we had helpers, we had strategists, we had people who just like to get tasks done, doers. So we had a nice range of kind of people. We also support a shared joy and sense of humor about the work, that it's work, but it's also a lot of fun, and we look forward to our time together. We do also believe in setting really specific goals and timelines and tasks. However, we don't tell people what to do. We collectively sort of say, what do we need to have before we meet next? Who can do what? what's on the plate, and people say, I can do this piece, okay, I can do that piece. And then in the interim time, we connect via email and electronically, of course. So, there are, of course, continued challenges. We face some challenges integrating new members into the group because once you get established and you have a lot of close relationships, it's hard for new people to feel joined, and so you have to be very deliberate in that process. Our backbone organization, the funding and sustainability, that's out of our hands and control, but having some sustainability of the coalition more nested in seems like it would help us. We have made efforts, but I think we could do more to strategically acknowledge the expertise of our members to keep them engaged, like to notice, hey, you do this for this project. That really helps. And then, of course, like all volunteer groups, we have a lot of turnover in terms of some group members have retired and some have had health problems. And so, you want to continually sort of bring new people in because of that. So we think that changing culture, which is really, what motivated us is to change the culture in the pharmacy, but also the culture in the providers, the health department. It does require these engaging a lot of stakeholders and organizations and establishing this organizational shift. And that's where the policy people really come in, because once you embed a policy and a procedure, that when you have a patient that has a blood sugar level of this is what happens, and this is how the provider is contacted, and this is what we do to keep that patient safe, then it takes on a life of its own. So we're really working on what the institutional policies need to be to solidify the integration between the two healthcare agencies, basically the pharmacy and the FQHC. This slide is just to show you that we really do have a study, and that we're working hard on it. It has 3 different groups that you random assign to, and we're in the data analysis stage. We finished collection right before Christmas, so yes, it took a long time to actually do this, but we're on to our next step. And then we wanted to show you some additional resources. So the paper that you heard about today is published in Johns Hopkins in a special issue. This is the link to the Gulf States Health Policy Center. We have a link here to the pharmacy. And then, of course, I'm at the USA Department of Psychology if you have any additional questions for us. And then I think that's where my part ends. And now, Carolina, I'm turning it back to you.
All right. Before we get into questions, it sounds like somebody has a radio on in the background. So if that's you, can you please shut it off? Thank you. And one more thing, while I'm asking questions, if you all have any questions for the presenters, you can enter them in the chat box in Skype, and then I'll be able to read them to the presenters once we finish these 3 questions on the slide. So my first question is, you talked a little bit about different steps you took related to the transtheoretical model that helped your work group become more productive. But what are some first steps you would recommend for coalitions to take when they're trying to develop a more productive work group? Hello. Dr. LR, Emily, Sherry, did you hear my first question or no?
Sorry, we were on mute. We were trying we were on mute. We were trying to limit our own background noise. So I just answered it. This is Emily, but I'll answer it again. I'm like the unlucky duck today. So the first thing I would say about building a strong coalition is diversity, that you have to have a diversity of organizations at the table. So your local government, your university or community college, nonprofits, community members, really look private businesses, look at people who you haven't maybe thought about before as partners. That's really where the strength of this coalition has come from, is by introducing people from different sectors to each other, and everybody brings something different to the table. And with health, you really need all those partners together. And the other thing I would say is creating an action plan and revisiting it on a regular basis so that everybody's really clear about what you're doing, why you're doing it, and they can see their own personal stake in it. And it's, of course, a living document. You don't have to be married to it, but revisiting it, at least quarterly to make sure that everybody knows that we're doing this for a purpose is what I would say.
Thank you. And then my second question, I think you've already touched on it somewhat, but what are some best practices for keeping volunteers engaged in a coalition? That's really, I think, a big issue for substance abuse prevention coalitions and other coalitions. So we'd love to hear your thoughts.
I think this is Dr. Alar. I think that people want to be seen, and seen both for their contributions to the group, but also seen as people. So when they miss a thing and they come back, we had a person who didn't show up for a couple meetings. We reached out, we called, we're like, we missed you, we want you, your expertise is valuable to us. So I think people want to be seen as people that other people care about, but they also want to be seen as valuable part of the work and recognized for that. So we don't disseminate things without trying to get everybody who has a skin in the game to look it over, to talk about it. We have meetings in person or on phone. We really try to say your voice, your particular voice is important to us. And I think that's actually pretty important.
And to add to that, I would say allow the member to discuss what's happening in their organization at each meeting, and because that's a part of the relationship building, to get to know a little bit about each member and what they're doing, and also build some type of portal or email blast where the member will have an opportunity to share events and invite other members to events and opportunities outside of the coalition, because that will help with the relationship building.
And this is Emily. I'll just add one thing from the Policy Center's perspective. We really tried to invest in our coalition members. So we tried to bring in as much training as we could, but we also sent them to leadership training whenever we could. We sent them to academic conferences to present papers on what they were doing as part of the coalition. So as that sort of supportive organization, we tried to give them as much recognition as we could.
All right, and then my final question is, in addition to the resources regarding your research that you provided on the previous slide, are there any other resources about coalition building that you could recommend to viewers, maybe that you used in the process of building your coalition, or just things you've come across?
This is Emily. I don't really have any other resources to share, but I just wanted to kind of reemphasize our policy and research focus in the coalition. I think that that's one thing that helps differentiate this coalition from other coalitions I know that I've been a part of, where you're focused on programmatic solutions. So I would just encourage people to think about maybe taking a research or a policy angle to a coalition. I think it decreased competition, as Dr. LR said, and just helped everybody sort of get on the same page but I don't really have any additional resources to share.
All right, then we'll move on to questions from the audience. I found one so far in the chat box. Well, two actually. One, to get it out of the way, I can answer it. We will be posting a recording of this webinar on the CADCA website. So that'll include the slides, so you'll be able to take a look at that and get access to the links that are in the slides as well. If you do just want a copy of the slides rather than looking at the recording, you can go ahead and email me. I'll put my email in the chat box, and then I can send you a copy. And then there is a question from Erica. Can you share tools of how you measured member networking? So I think this is in reference to the slide you showed with the different, the like pre-coalition network where there weren't as many connections and a lot of people out on the edge versus the lots of connections in 2016.
Sure. Here's Emily's going to talk a little bit about the work we did along those.
Okay, so we worked with Dr. Candace Bright, who is now at Eastern Tennessee State University. She's our social network analysis guru and hero, and she designed a survey that I think was done through SurveyMonkey, and was done I think every 6 months to measure the social network analysis. So that's another reason why it's great to try to find someone at a university, because they know how to set those surveys up and how to do that and get that data to show that your coalition is actually creating these connections. So that's who we use. There are certainly, Candace is great, and I encourage any of you to reach out to her because I know she would be open to it, but there are certainly others that know about social network analysis who could help you locally.
So just as a member, this is Dr. LR, what the survey would come, and it basically would list a bunch of people. I actually wish it had pictures too, because I'm not as good with names. But, you know, it would list the names of people and it would essentially say, do you know this person? And then yes or no, do I know this person? Where do I know them? Have I met with them outside the group or not? If so, in what other context? So it not only got like how many people do you actually like feel like you know their name, know that they're in this coalition, know who they are, but also what is the depth of relationship that you have with them. So the way social network analysis works is the thicker the lines and the denser that sort of network looks, the more the relationships are utilized and the more they cross multiple pathways. And I think that speaks to what Sheree was talking about. I'm so excited. Sheree actually got nominated by our city council to have her own day. So there was a Sheree Archer Day in Mobile, Alabama, and it was December 14th. And so, you know, once I know who Sheree is, you know, who I had no relationship with before this project, now I'm wanting to celebrate that. I'm telling people about that. I'm sharing that. Likewise, I was on a panel, a women's forum panel. She saw my name. She came to the forum. So what happens is once you cross this threshold, then you start having more and more connections. Social network analysis uses a series of questions to basically plot that out across time. And they show how some people are being moved into the center of the group or closer into the center of the group and have deeper and deeper relationships with other people. It actually probably is a really good tool, too, to look at like people who that doesn't happen. Like who are the people that they don't move into the group? And, you know, what you can't see from that is some of the people who are still at the outskirts at the next time are people that are new to the coalition. So they, you know, they just haven't moved in yet to those things. So it's a very interesting kind of analysis.
Thank you. Erica has another question that's sort of related to that. My challenge managing a community coalition is finding the people who advocate for policies. Research is less risky than speaking to elected officials, media, writing op-eds, etc. How do you find more members able to do that?
Okay, so these are really good, really in the trenches, hard questions. So one of the very complex things about our coalition was because it was funded, the larger backbone organization was funded by NIH, we're actually not allowed to advocate if our project is coming from that money, because NIH has rules against advocating. So our actual policy group, our work group, can fund research, can conduct research, and we can summarize existing data and write white papers, that give evidence papers that can be used by people who are advocating, and we can get those in the hands of people who are already in positions of advocating. What we discovered, though, is that there's some people in a large group, there's some people who are already advocating, right? And so by increasing their network, by figuring out who those people are and increasing their network and providing them with better arguments and better information, those people then are more successful than they were prior to the coalition. And they're also the one, like in our case, our pharmacist, he was already advocating for MTM, but what he didn't have was any data to say that this would work in Alabama. And in our state, if the data is from the East Coast or if it's from California or some other place, we're very skeptical that that means much for us. And so sometimes to have local data, even if it's something that's been done in a lot of other places, is really important for people that are making the laws and rules. So, for him, he was already an advocate. He was doing a good job, but he needed tools, and this policy group can provide those tools.
Questions for the presenters, you can go ahead and answer that or send them in the chat box. One thing I will mention is Linda asked about getting a letter of participation. So if you do want a letter of participation or some kind of reading or something like that, you can send me an email at kduce@cadca.org. It's in the chat box. You see it in there. If you send me an email, I can send you a letter. All right, Ashley W. has a question. Can you give advice on ways to reach out to new members?
I think I'll just reiterate what I've said before is it's really important to think outside the box in your membership, to think about people who you haven't seen at the table and to encourage your members to do the same. Because all of the people who are sitting in the room, you have 15 people in a room, they all have their own network. So I think one of the things that we really did is regularly encourage the members that we had to reach out to their own network. And we had regular communication. We would also send out, things that they wanted to send out to the coalition from their own organizations. And so that became kind of a value add of being involved in the coalition, is that you could get your own stuff, sent out. So I think also think about where your audiences are getting their information. There are some groups that use email. There are some groups that use social media. There are some groups that use direct mail. So thinking about how you communicate, working with your city government to get notices out using their platforms. So I think just being really creative and diverse in the way that you think about who you're trying to reach and how you're getting your information out.
I think your point about communications is well taken. Everyone has their own preferred mode, but it's important to think about what other people that you're trying to reach may prefer instead, or in addition to, I guess. Do we have any more questions? Well, I don't see anyone typing, so we'll go ahead and and Emily and Cherie, and their colleagues for writing this paper and also for presenting their work to us this afternoon. And thank you for everyone for joining in today and listening. If you want more information about this webinar, you can email evaluation@cadca.org, or I put my other email in the chat box, knews@cadca.org. And the next webinar will probably be in March, so keep an eye out in your email inboxes. Thank you.
Thank you, everyone. We really enjoyed having a chance to share our work with you, and we're sorry for the glitches, but thank you so much for letting us speak with you all.